The House Health Policy Committee will come to order. If everyone could please take their seats. Would the clerk please take attendance?
Chair Rogers.
Here.
Representatives Whitsett. Carter.
Here.
Hadsma.
Present.
Neely.
Here.
Glanville.
Here.
Kafia.
Here.
Conlon.
Here.
Farhat.
Here.
Fitzgerald.
Here.
Miller.
Here.
Reingens.
Here.
Vanderwall.
Present.
Filler.
Yes.
Mueller.
Here.
Van Workum.
Here.
Roth.
Here.
Schmaltz.
Here.
Thompson.
Here.
Madam Chair, you have 18 members present. You do have a quorum.
Thank you. Representative Farhat moves to approve the minutes from our meeting on May 25th. Seeing no objection, minutes are approved. Today we will be voting on Senate Bills 69, 70, 71, and 72. Senate Bill 72 was re-referred to our committee earlier this week and is a companion bill to Senate Bill 69 and 71. We heard testimony on these 2 weeks ago. In addition, we have a substitute for SB 71 to consider before voting to report. We will then hear a report from the Behavioral Health Subcommittee on House Bills 4616 and 4617 from Committee Chair Brabeck. It is my intention to also vote these bills to the floor after hearing the report from Chair Brabeck. Finally, we will take testimony on Senate Bill 219. First up our agenda, we will be taking up Senate Bill 69 through 72. As we just received this bill from Criminal Justice Committee, we will first hear testimony on Senate Bill 72, which provides penalties for violations included under SB 69 and 71. To speak to her bill, we have Senator McDonald Ribbit. Senator, welcome to Health Policy, and thank you for coming over. Start whenever you are ready.
Thank you very much, Madam Chair. This is the first time I've testified over in the House, so I'm excited to do it with your committee. I am grateful to be here, and thank you to the Chair and members of the committee for the opportunity to speak to Senate Bill 72, and with your permission, talk a little bit of the package as a whole. Thank you to the advocates and the many previous sponsors of these policies. We would not be here today without the work that they have all done on this critical legislation. Senate Bill 69 would prohibit medical professionals from performing specific medical procedures and examinations on minor patients unless a medical assistant or other medical professionals are in the room and the minor's parent or guardian have consented. Senate Bill 71 would establish a minimum of a 15-year retention for licensees providing vaginal and anal penetration examinations. A licensee must expressly document in a patient's medical record that these services were performed. My bill, Senate Bill 72, would amend the sentencing guidelines in the Code of Criminal Procedure to include the felonies proposed by Senate Bill 69 and 71. These bipartisan bills are common sense, they protect victims, and they ensure that critical evidence is preserved, allowing us to hold bad actors and, frankly, predators accountable for their actions in the future, as time progresses, particularly when there is verifiable proof of wrongdoing during investigations. Michigan must send a strong message of accountability and taking patients' rights seriously, particularly given the happenings of the last decade. I want to thank you for giving time and consideration to this package of bills. I believe it is incredibly important that we send a message about the importance of not just protecting victims, but preserving evidence so that there is a strong possibility of criminal liability, holding predators accountable and criminally liable, and when victims come forward. Thank you.
Thank you so much. I'm going to take chair point of privilege and just ask, could you briefly talk about the history of this particular bill? Have we had this bill up before in past terms?
This has been, as a freshman legislator, one of the things I'm learning is that there are not a lot of original ideas. This is a package of bills that was brought forward when the beginning when the evidence of the Nassar case started coming forward. We know victims often can come forward in their own time. You can't rush people through their trauma. And what we see is that many years often go by until a victim feels that they have the wherewithal to bring these sorts of things into public light. So there was a package of bills that was moved in the wake of the Nassar cases. They did not go far enough. This is intended to be a companion to those. They have been introduced before, but did not get appropriate traction. And we're very optimistic, particularly since we have a large group of stakeholders and bipartisan support.
Thank you so much. Are there any other questions from members? Thank you so much. I will let you run across the road back to your session.
Thank you.
We appreciate you. I think we have some cards to read in. So we've got Michigan Catholic Conference supporting Senate Bill 69 through 72. We have Michigan Family Forum supporting Senate Bill 69 through 72. Michigan Council of Maternal Child Health supporting Senate Bill 69 through 72. And Michigan Nurses Association supporting Senate Bill 69 through 72. We will go at ease. One moment. Call the chair. Household policy will come back to order. Representative Kafia moves to report Senate Bill 69 with recommendation. Madam Clerk, please take the vote.
Chair Rogers.
Yes.
Representatives Witset, Carter,
Yes.
Hadsma,
Yes.
Neely. Yes. Glanville,
Yes.
Kafia,
Yes.
Conlon,
Yes.
Farhat,
Yes.
Fitzgerald,
Yes.
Miller,
Yes.
Reingans,
Yes.
Vanderwall,
Yes.
Filler,
Yes.
Mueller,
Yes.
Van Workum,
Yes.
Roth,
Yes.
Schmaltz,
Yes.
Thompson.
Yes.
Madam Chair, you have 18 yeas, 0 nays, and 0 passed. Senate Bill 69 is reported with recommendation.
Thank you. Motion carries. Representative Miller moves to report SB 70 with recommendation. Madam Clerk, please take the vote.
Chair Rogers.
Yes.
Representatives Witset, Carter,
Yes.
Hadsma,
Yes.
Neely,
Yes.
Glanville,
Yes.
Kafia,
Yes.
Conlon,
Yes.
Farhat,
Yes.
Fitzgerald,
Yes.
Miller,
Yes.
Reingans,
Yes.
Vanderwall,
Yes.
Filler,
Yes.
Mueller,
Yes.
Van Workum,
Yes.
Roth,
Yes.
Schmaltz,
Yes.
Thompson.
Yes.
Madam Chair, you have 18 yeas, 0 nays, and 0 passed. Senate Bill 70 is reported with recommendation.
Thank you. Motion carries. Members, we do have an amendment to SB 71 from Vice Chair Vanderwall. Vice Chair Vanderwall, will you please speak to your amendment?
I will. Thank you, Madam Chair. The amendment is intended to create important record-keeping requirements for healthcare providers and healthcare facilities like doctors, offices, and hospitals due to the existing definition of healthcare facilities and agencies in the Public Healthcare Code, which include health maintenance organizations like HMOs, would be inadvertently subject to these requirements even though they have no actual involvement in a patient's medical care. This amendment will clarify that these requirements are not intended to apply for HMOs.
Thank you. Are there any questions? Seeing none, Vice Chair Vanderwall moves to adopt his amendment, SB 71, with recommendation. Madam Clerk, please take the vote.
Chair Rogers.
Yes.
Representatives Witset, Carter,
Yes.
Hadsma,
Yes.
Neely,
Yes.
Glanville,
Yes.
Kafia,
Yes.
Conlon,
Yes.
Farhat,
Yes.
Fitzgerald,
Yes.
Miller,
Yes.
Reingans,
Yes.
Vanderwall,
Yes.
Filler,
Yes.
Mueller,
Yes.
Van Workum,
Yes.
Roth,
Yes.
Schmaltz,
Yes.
Thompson.
Yes.
Madam Chair, you have 18 yeas, 0 nays, and 0 passed. The amendment is adopted.
Motion passes. Thank you. Representative Vanderwall moves to report SB 71 with recommendation as amended and as substituted. Madam Clerk, please take the vote.
Chair Rogers.
Yes.
Representatives Witset, Carter,
Yes.
Hadsma,
Yes.
Neely,
Yes.
Glanville,
Yes.
Kafia,
Yes.
Conlon,
Yes.
Farhat,
Yes.
Fitzgerald,
Yes.
Miller,
Yes.
Reingens,
Yes.
Vanderwall,
Yes.
Filler,
Yes.
Mueller,
Yes.
Van Workum,
Yes.
Roth,
Yes.
Schmaltz,
Yes.
Thompson.
Yes.
Madam Chair, you have 18 yeas, 0 nays, and 0 pass. Senate Bill 71 is reported with recommendation as amended as a new sub.
Thank you. Motion passes. And now Representative Neely moves to report SB 72 with recommendation. Madam Clerk, please take the vote.
Chair Rogers.
Yes.
Representatives Witsett, Carter,
Yes.
Hadsma,
Yes.
Neely,
Yes.
Glanville,
Yes.
Kafia,
Yes.
Conlon,
Yes.
Farhat,
Yes.
Fitzgerald,
Yes.
Miller,
Yes.
Reingens,
Yes.
Vanderwall,
Yes.
Filler,
Yes.
Mueller,
Yes.
Van Workum,
Yes.
Roth,
Yes.
Schmaltz,
Yes.
Thompson.
Yes.
Madam Chair, you have 18 yeas, 0 nays, and 0 pass. Senate Bill 72 is reported with recommendation.
Motion passes. I want to just personally thank each one of you for that unanimous vote on this important package of bills. I am proud that I am going over to the Senate to testify this afternoon on some of the House bills. So thank you for your confidence, and I am very excited to continue to do the work to protect protect survivors and prevent additional sexual assault in our state. We have a letter from Chair of the Behavioral Health Subcommittee in regards to House Bill 4616 and House Bill 4617. Madam Clerk, could you please read the letter?
Chair Rogers and members of the committee, pursuant to Rule 34 of the Michigan House of Representatives, the House Health Policy Committee, further referred to as committee, created the Subcommittee on Behavioral Health Policy Subcommittee, further referred to as subcommittee. On May 25th, 2023, the committee referred House Bills 4616 and 4617 to the subcommittee for its review. The subcommittee met on June 7th, 2023. A record of this meeting has been filed with the subcommittee records. I request that this record also be made part of the permanent record of the House Health Policy Committee. During the meeting, subcommittee members heard testimony from the bill sponsors and from several stakeholders in support of and a few stakeholders in opposition to the bills. With the requisite number of votes in the affirmative, the subcommittee voted that the bills be returned to the full committee without amendments and with the recommendation that the bills be reported to the full House. Sincerely, Felicia Braybeck, Chair of the Behavioral Health Policy Subcommittee.
Thank you. Representative Braybeck is here with us today and will share an overview about the work the Behavioral Health Subcommittee did on these bills. Thank you so much, Chair Braybeck. Begin when you are ready, and she will be available for questions afterwards.
Thank you, Madam Chair, members of the committee, for allowing me to testify this morning in front of you. As the letter stated, on May 25th, Chair Rogers asked that the Behavioral Health Policy Committee take up House Bills 4616 and 17. This is a bill package that I've worked on with Representative Hoskins and Senator McMorrow. Yesterday, the committee heard testimony and voted on those bills. These bills would ban the practice of conversion therapy. Conversion therapy is a practice of attempting to change an individual's sexual orientation, gender identity, or gender expression to align with heterosexual or cisgender norms. Speaking to you as a licensed mental health care practitioner, I can assure you that this practice is not therapy at all. It is a pseudoscientific, dangerous, and damaging practice that lacks a credible, evidence-based premise. Folks who receive conversion therapy are more likely to experience severe depression and anxiety, substance use and abuse, and increased suicidal ideation, intent, and attempts than peers who don't. In fact, the Journal of the American Medical Association recently published a study that addressed both the humanistic and the economic impacts on our young adults who have been on the receiving end of conversion therapy. This is what they found. They found that conversion therapy may exacerbate distress or incite guilt, shame, and self-hatred, and is associated with devastating mental and physical health consequences, including new or increased depression, anxiety, self-harm, suicidal ideation, nightmares, gastrointestinal distress, sexual dysfunction, relationship problems, and isolation. Economically speaking, they found that the downstream consequences associated with lifetime excess costs are around $84,000 per individual. And that's because the individual is put at risk primarily associated with suicidality, anxiety, the severe psychological distress, depression, and substance abuse. So if we take a 30,000-foot view, a population perspective on this, that translates to about $650 million for change efforts, just in 1 year alone. And the harms, the associated harms, are an estimated $9.2 billion in terms of economic burden for our communities. Many states have recognized this impact on both a humanistic and economic levels and have taken steps to ban this practice. We would be the 22nd state to do that. It's noteworthy that of the 21 states who have banned the practice of conversion therapy, of those states' laws, 7 were enacted by Republican governors. And in fact, New Jersey was the second state in our country to ban the practice, doing so a decade ago in 2013 under then Governor Chris Christie. And in 2020, Utah banned conversion therapy. Originally, their ban was signed into effect by Republican Governor Gary Herbert, and most recently, Republican Governor Spencer Coy signed it into law, and it was voted out of their legislature unanimously. And I say all of this to say that this is an issue with bipartisan support. There are many associations who support the banning of the pseudoscientific menacing practice. Some include the American Medical Association, the American Academy of Pediatrics, the American Psychological Association, the American Counseling Association, Mental Health America, the American Psychiatric Association, the American Federation of Teachers, and the National Association of School Nurses, just to name a few. Yesterday in committee, we had 15 people testify, either in person or via Zoom. 12 testified in support of the bills and 3 in opposition. 15 cards were submitted to the committee, 12 in support, including our Attorney General and the Department of Health and Human Services, and 3 of those cards were in opposition. Both of the bills were voted on yesterday. The votes were the same for both bills, 7 yeas, 4 pass, and 0 nays. I'd be happy to answer any questions now, Madam Chair.
Thank you so much for that update. Representative Filler.
Sure, and I've always had a concept in my mind. I see this in the news,
Sure.
conversion therapy, and I've had a concept that somebody puts it on their signpost. You know, I practice conversion therapy. Come to me if you are. I can help you. You know, stop being a homosexual or something. That's how I envision it in my mind, without having any real knowledge of what the practice looks like. But that's not what's in the bill. The bill is much more the back and forth with the individual who comes into the psychologist's office. And so the way I read it, if an individual came in and said, I guess I'm a homosexual and I don't want to be a homosexual anymore, that they could not engage regarding that. Is that how you read it too?
So, no, that's not how I read it.
Okay.
So therapy.
I'd love more information.
Absolutely. Happy to do it. So the process of therapy is a conversation, not a yes, no. You know, and so in any of the work, I feel lucky enough as a therapist, and just so folks know, I've been able to practice therapy for almost 30 years with folks, and I do a lot of identity work, racial identity, sexual orientation, gender identity, and it's a conversation that happens. There's an exploration, and that actually happens with any of the work that we do when we come to therapy or go to therapy is an exploration of whatever said issue is. What this is an explicit ban on conversion therapy, which is explicitly saying to someone, who you are is not okay and is wrong. And that's not what we do in therapy.
In my hypothetical that I gave you, there could be a back and forth with the individual who said, you know, I'm a homosexual, but I'm really struggling with it, or I'm transgender, I'm really struggling with it. I want to go back, or I don't want to be like this anymore. There could be a back and forth between the individual and the psychologist, but the psychologist just couldn't specifically say, I'm going to help you not be homosexual anymore.
That's correct. Again, it's a conversation that happens, and the work that we do is also for most of us who practice therapy, it is client-centered. And so that means that clients are the ones who are leading the practice, and we use different therapeutic modalities that are evidence-based. Conversion therapy is not, to be able to help that person navigate whatever the issues are, identity included.
Thank you. Representative Glanville.
Thank you, Madam Chair, and thank you, Representative, for being here today. As you know, I was in the Mental Health Committee yesterday, the subcommittee yesterday, and just to kind of follow up on our colleagues' questions here, I found it very compelling to hear the details of conversion therapy. I was unaware of the physically torturous practices that take place, that people described being counseled to not speak to feminine relatives, sisters and mothers and such for years, and also self-torture in terms of applying heat or ice to the genitals in response to imagery, being advised to take performance-enhancing drugs to encourage their sexual desire for a particular gender.
That is correct.
So yeah, those, and that's what I wanted to clarify. Those are all.
Yes, that is what conversion therapy is. Conversion therapy is not.
So we're not
therapy.
talking about this conversation
That's
where you
right.
explore how do I think, how do I feel, what does that mean for me? It really is a physical attempt to physically train yourself to behave in a certain way.
As one part, and it can also include electric shock. I mean, many torturous things. Again, that there is no proven and scientific basis that changes fundamentally who someone is. It does not work and is not appropriate to do with folks.
Okay, thank you.
Yeah, absolutely.
Representative Thompson, and then I'll come back to Filler if no one else has had questions.
Thank you, Chair. Well, Representative Brayback. So if conversion therapy is seen in physical and not conversation, if we're looking at conversion therapy as the practice of electroshock of children, because this bill relates only to minors,
kids.
correct? So I think I would agree, and everyone in this room would agree that we should not be torturing our children. We should not be torturing them or messing with them at any level because they're just kids. So when you mentioned identity and supporting their identity, that their identity is enough, and you are a therapist, as a parent, if I were to bring you a 6-year-old child and I would say that they're struggling with their identity, if we were to ban conversion therapy, what would that conversation look like with you and that child? If they were confused, they were a boy and they said they thought they might be a girl. We don't have conversion therapy on the table. What would that conversation look like?
So what's hard to do is to synthesize a conversation that sometimes could take years into, a couple-minute interaction here. But again, the premise both includes any of the physical manifestations of this, but also talk therapy. And when you're in therapy, it's not a one and done, right? You don't have just one conversation and then, okay, everything is finished and we're done and we're going to move on. It is, and with kids, you're going to do different things. There might be play therapy, which is empirically based. There might be some talk therapy, but you use the example of a 6-year-old, and so that would look different than like a 14-year-old. And so the therapist would employ those evidence-based methods to be able to engage with that child about whatever the questions are, and the exploration would be open. I mean, that's what we do when we just have affirming care in general. I'm not talking about just as a therapist. That's part of what we do when folks come to us is offer that safe space to do no harm and have questions. But when we know that there are harmful practices out there that are continued to be perpetrated, we want to put an end to that.
You said affirming. So you would affirm that the 6-year-old was a girl if they said they were a girl.
When I just said that, affirming, like anyone who comes in, part of the space that we create for folks is one of trust and affirming, no matter what folks are coming in for. We want to be able to open up the conversation to be able to, if someone comes in and we're like, you're wrong, and we're going to shut off this conversation and I'm going to change you, people shut down and they don't engage. And then we have all the things that I was talking about here. Again, regardless of what the issue is. We want to provide, as a therapist, a safe, welcoming space for folks to be able to explore whatever the issue is that they want to explore. Yeah, of course.
Representative Roth.
Thank you, Madam Chair. Thank you, Representative
Sure.
Raybeck. A little concern over or maybe clarification.
Sure.
The registered nurse part of the bill. Is this a registered nurse that's in the mental health field, not necessarily one in orthopedics, let's say?
So this is defined through the mental health code. So it refers to the mental health code. So anyone who comes into contact with kids and that's part of it. Again, that's part of our code that already exists. Yeah.
Thank you. Thank you.
Thank you. Seeing no others, back to Representative Filler.
I guess maybe this is a learning experience for me, but the bill bans seeking to change essentially an individual's behavior or sexual orientation or gender identity. And I guess I was under the impression that a lot of therapy is in fact an effort to change behavior, but you're saying that not in this specific case.
That is correct. People are who they are. Just as if I went to therapy, I'm straight. If I went to therapy, that I wouldn't walk in expecting that to be changed. Any identity is part of who we are. The things that I think you're alluding to are characteristics that we come into, or that we have and then we come into therapy with. Two different things.
Thanks, Chair. Thank you, Representative.
Absolutely.
Once, twice. Okay, I think we are good. I'm going to read in cards a second. ACLU of Michigan supports 4616 and 4617. The Department of Health and Human Services supports 4616 and 4617. Equality Michigan supports both bills. National Association of Social Workers supports both bills. American College of Obstetrics and Gynecologists supports both bills. Michigan Association of School Social Workers supports both bills. Michigan Association of School Psychologists supports both bills. Michigan School Counselors Association supports both bills. Michigan Council of Maternal and Child Health supports both bills. Michigan Nurses Association supports both bills. Michigan Catholic Conference opposes the bill, and Michigan Family Forum opposes the bills. And I understand Minority Vice Chair Vanderwall has a amendment.
I do. Thank you, Madam Chair. Basically, the amendment that I'm offering just tightens up the language. And if you look at the amendment, it has three different pieces, but it tightens up the language to eliminate the concerns that we have about children receiving gender transition therapy. The current bill as written still allows for doctors to provide advice that a child should have surgery to change their assigned sex at birth, often involving surgical removal of sexual organs. Let me be clear, we don't support shock therapy or harmful methods used on children that are choosing this lifestyle to try to change their sexual orientation. Then why should we not support the same kids being encouraged by their doctor to have irresponsible and irreversible surgeries done on their sexual orientation? These amendments would get rid of the vagueness and allow a doctor who knows their patient the best to encourage the proper course of action.
Are there any questions? Okay, so we are on the second bill, correct? I didn't quite understand that. So this is an amendment to 4617. Okay, so Representative Vanderwall moves to amend 4617 as outlined. Will clerk please take the roll?
Chair Rogers.
No.
Representatives Witsett, Carter,
No.
Hadsma,
No.
Neely,
No.
Glanville,
No.
Kafia,
No.
Conlon,
No.
Farhat,
No.
Fitzgerald,
No.
Miller,
No.
Reingans,
No.
Vanderwall,
Yes.
Filler,
Yes.
Mueller,
Yes.
Van Workum,
Yes.
Roth,
Yes.
Schmaltz,
Yes.
Thompson.
Yes.
Madam Chair, you have 7 yeas, 11 nays, 0 passed. The amendment is not adopted.
Thank you. So we are going to go back now to 4616. Representative Reingans moves to report House Bill 4616 with recommendation. Madam Clerk, please call the roll.
Chair Rogers.
Yes.
Representatives Woodsett, Carter,
Yes.
Hadsma,
Yes.
Neely,
Yes.
Glanville,
Yes.
Kofia,
Yes.
Conlon,
Yes.
Farhat,
Yes.
Fitzgerald,
Yes.
Miller,
Yes.
Reingans,
Yes.
Vanderwall,
Pass.
Filler,
Pass.
Mueller,
Pass.
Van Workum,
Pass.
Roth,
Pass.
Schmaltz,
Pass.
Thompson.
Pass.
Madam Chair, you have 11 yeas, 0 nays, 7 pass. House Bill 4616 is reported with recommendation.
Motion passes. Thank you. And moving on to House Bill 4617, Representative Carter moves to report HB 4617 with recommendation. Madam Clerk, please take the vote.
Chair Rogers.
Yes.
Representatives Woodsett, Carter,
Yes.
Hadsma,
Yes.
Neely,
Yes.
Glanville,
Yes.
Kofia,
Yes.
Conlon,
Yes.
Farhat,
Yes.
Fitzgerald,
Yes.
Miller,
Yes.
Reingans,
Yes.
Vanderwall,
Pass.
Filler,
Pass.
Mueller,
Pass.
Van Workum,
Pass.
Roth,
Pass.
Schmaltz,
Pass.
Thompson.
Pass.
Madam Chair, you have 11 yeas, 0 nays, 7 pass. House Bill 4617 is reported with recommendation.
Motion carries. Thank you. Thank you, Chair Braybeck and your Behavioral Health Subcommittee for the important work on these bills to further protect Michiganders. Appreciate your work. Finally, thank you for waiting so patiently. We will be taking up Senate Bill 219 to testify in support of the bill. We have Nicholas Cook, Chief of Staff for Senator Santana, followed by Eric Roth from Michigan Pharmacists Association, Amy Drum with Michigan Retailers Association, and finally Michael Sleeman with Walgreens. To provide an overview of the legislation, we will start with Nick Cook from Senator Santana's office. Start when you're about. Thank you. Welcome.
Thank you, Chairwoman Rogers and members of the committee. I'm Nick Cook, Chief of Staff for Senator Santana. She apologizes she could not attend today, but is currently in session. We thank you for considering Senate Bill 219. Under the Federal Preparedness and Emergency Preparedness Act of 2020, pharmacy providers across the country were approved to provide a broad array of immunizations and to test to treat services during the public health emergency. Utilizing the full pharmacy team, including pharmacy technicians, to provide critical access to affordable services in many underserved communities. The Federal PrEP Act allowances expired on May 11th. Now, as many of you know, this was expanded to allow some of the Federal PrEP Act to be continued until December 31st of 2024. But that did not allow for childhood immunizations. So what this bill does is codify in state law the ability for pharmacists to order and administer vaccines for those ages 3 and above. There's also some very key components based on work with stakeholders and the department. What this does is codifies the age to 3 and above for pharmacists to provide the vaccines. Solidifies the rulemaking process that includes promulgation of rules for training that includes direction on administering vaccines and having sufficient knowledge of how to treat within the scope of the bill, COVID-19 and influenza. It includes language to protect procedures already done under collaborative agreements and allows pharmacists and new pharmacists to continue childhood vaccinations, COVID, flu, past the May 11th deadline while rules are being promulgated. Additionally, this requires those above the age of 21 to be entered into the MICR within 72 hours. This is in alignment with those under the age of 21 that is already current law. This also adds a definition for qualified immunizing agent to more closely align with vaccines that were allowed under the Federal PrEP Act, and ensures that patients that may qualify for the Vaccines for Children program have out-of-pocket costs that are made aware to those individuals. Let me see here. Pharmacists have effectively connected millions of patients during the pandemic. including those who do not otherwise have a primary care provider. Without continuing this practice, there will be a critical gap in care resulting in patient confusion and frustration. 64% of Michiganders believe learning that the lessons of the pandemic means keeping in place policies that make it easier for patients to access services for pharmacists and other pharmacy team members. Since 2021, 18 states have broadened vaccination authority and 16 have granted permanent vaccine authority to pharmacy technicians. I want to thank all the stakeholders and the departments for working on this bill, Senate Bill 219, and stand by for any of your questions.
Thank you. Do members have any questions for Nicholas? Representative Thompson. Oh, sorry. Minority Vice Chair Vanderwall first.
Thank you, Madam Chair. And thank you for your work on this bill. If you could get a little more in detail, can you walk us through what you've seen through the expanded rules right now with child immunizations and where we've moved back the rates? Have we seen an increase of the rates through this, or are we still suffering from pre-pandemic levels?
Chairman, Vice Chair Vanderwall, good to see you again.
Nice to see you.
There has been a lack of vaccines follow-ups. We are afraid that if this is rolled back to pre-pandemic rules, that there will be an even sharper drop-off of children vaccines. We have noticed that people have put off care during the pandemic, including going to their pediatricians. We worked very closely with the department, and Amy Zagman, I believe, put in a card talking about some of their concerns with this. But really what it is about access. Give parents options to get their child vaccinated. And that's what we want to see. We believe that this will increase vaccination rates amongst children.
Thank you. And then, Madam Chair, if I may ask one more, thank you. Also, if reading through this bill and just understanding a little bit, this will also, in most cases, reduce that extra doctor visit. Is that correct? Is there do they, because of being able to have this done right at a pharmacy, do they still go through the normal channels of visiting their doctor, or can this be done in lieu of that?
For the vaccinations, I guess is your question, Chairman?
Correct.
Yes, that would allow the vaccine to be administered directly to children as long as it's in coordination with the Advisory Committee on Immunization Practices for those 3 and above.
Thank you.
But I think as a point of clarification, he was also asking, this isn't designed to replace primary care visits.
Correct. This is in coordination with primary care visits.
Thank you. Representative Thompson.
Hello, thank you very much. So, in order to vaccinate children, what type of training does the pharmacy tech have to go through, and who would be monitoring any possible reactions to the vaccine? Would that be the parent's responsibility, or would there be a medical professional such as a nurse on staff to be able to monitor for reactions right after the injection?
I'll let the Pharmacists Association kind of go into detail on how that works at the place, at their facilities. However, these are all practices that are being done right now. And throughout the entire pandemic, we did not see any adverse reactions as far as emergencies raising out of this. And that's why we are trying to codify what has been done and what a lot of pharmacists already do through collaborative agreements. And there isn't a nurse or a doctor on site in those cases.
Okay, thank you.
Representative Thompson, we'll come back to that question because I think some of the other testifiers will be able to address it. Representative Conlon.
Yes, thank you, Madam Chair, and thank you for your testimony. Do we know what the rate is for toddlers who are up to date in the state of Michigan on their vaccines? And I take it we're talking whooping cough and measles, mumps, tetanus, that kind of thing?
You're correct. I'll get back with you, Rep. Conlon.
Any other Representative Schmaltz?
Thank you, Chair. Thank you for testifying. Would every pharmacy have to require that they have a pharmacist to do this?
I guess I'm trying to understand your question. Yes, you need a pharmacist to order and administer the vaccines. They can use techs and interns to administer the actual vaccination.
But would every pharmacy in every place that has a pharmacy have to have somebody on staff to give out the immunizations?
We can have the next people.
Yeah,
We'll switch. We'll switch.
yeah.
We'll bring them up. That's
Thank
okay. I think we have several questions. So thank you so much for your testimony. If you want to stay up or if however you want to do it, but we're going to bring up Eric Roth with the Michigan Pharmacists Association, as well as Dr. Klepser. And if you can give your testimony, but also maybe address some of these questions that were raised. Thanks so much and welcome.
All right, thank you, Madam Chair and members of the House Health Policy Committee. Really appreciate the opportunity to testify on this very important bill. My name is Eric Roth. I am a licensed pharmacist, and I am currently also the Director of Government Affairs for the Michigan Pharmacists Association. This legislation is really a majorly important step to helping the citizens of Michigan maintain access to disease-preventing and life-preventing services. As is mentioned, during the COVID-19 pandemic, pharmacies were an essential access point for both vaccines and testing for this disease. To answer some of the questions that were asked earlier, pharmacists are required to receive training specific to the delivery of immunizations. Additionally, we are also required to be trained on basic life support services. I can tell you from my experience administering COVID-19 vaccines during the pandemic personally, we would set up protocols where patients would be monitored on site for the recommended window, and pharmacists were trained on how to maintain an individual that did have any kind of reaction, whether it be allergic or otherwise, while emergency medical services would be contacted. So I say this to emphasize that there are extensive protocols that are put in place at every pharmacy that offers these services, and it is all done under the personal supervision of a pharmacist. A pharmacy technician and a pharmacy intern can only be operating under the direct personal supervision of a pharmacist. I also want to talk about another aspect of the bill, which is the administration of simple, non-technical tests used to diagnose acute diseases such as COVID-19, or even in other applications, assess the markers of risk and progression of chronic diseases. These tests, as classified by the FDA, are known as CLIA-waived tests. So, to speak further on the topic of CLIA-waived tests, I would like to introduce you to a pharmacist who is one of the foremost content experts on this subject, in particular in the state of Michigan. Dr. Michael Klepser is a professor with the College of Pharmacy at Ferris State University. He is also a co-developer of the National Alliance of State Pharmacists Associations CLIA-waived Test and Treat Certificate Program, and has trained more than 8,000 pharmacists nationwide on the subject since 2015. Dr. Klepser is recognized as an international expert on CLIA-waived point-of-care tests and their application in community pharmacies in particular. Dr. Klepser.
Thank you, Madam Chair. Thank you, members of the committee. Thank you for allowing me to testify on behalf of this bill. From a point of a little historical perspective, these CLIA-waived tests are a subset of laboratory tests that are designated as simple to perform and have a low risk of erroneous results. There are currently more than 120 CLIA-waived tests that are approved by the FDA. And under federal regulations, these tests may be performed in a laboratory that has applied for a waiver of CLIA requirements. And this can include being done in a community pharmacy. CLIA-waived tests do not require, as a condition of FDA approval, any sort of prescription or medical order for their use. Pharmacists have been employing CLIA-waived tests, such as those to monitor blood glucose, cholesterol, influenza, and strep throat for decades in their clinical practices. In 2007, I had the opportunity to meet with Special Assistant for President Bush on biopreparedness and pandemic influenza. And at this point in time, we both agreed that community pharmacists and pharmacies represented critical infrastructure within the United States and could be leveraged more than they had been with respect to providing services in times of need. And what we determined was that according to their level of training and expertise, that pharmacies could play a huge role if they were able to use CLIA-waived tests to screen and treat for individuals in times of need. In response to this meeting, we engaged or embarked on creating a number of studies to evaluate the use of these tests, the safety and the efficacy of these test services in pharmacies. Additionally, we created the infrastructure at that point in time needed to train pharmacists who at that point in time really did not have the training needed to run a CLIA-waived lab or specimen collection. As a result of that, as Eric mentioned, we've trained over 8,000 pharmacists nationwide to provide these services. And when COVID-19 struck, I think we saw the fruits of that labor, that we were able to mobilize relatively quickly, and we are able to use pharmacists as essential testing points for COVID-19. In fact, in Kalamazoo County, where I'm from, 4 pharmacies alone accounted for over 30% of all of the COVID tests that were done during the pandemic. And if those individuals would have gone to traditional medical services, they would have overwhelmed the healthcare system. What was also recognized is that in order to lean on pharmacists in times of need, we had to allow them to practice these type of activities during times so they could recoup investment in equipment, laboratory tests, and gain the valuable experience. Since 2007, my group has helped pharmacists in the state develop disease management programs using CLIA-waived tests. Some examples in being the test-to-treat models that I've mentioned for COVID-19, influenza, strep throat, and sexually transmitted infections. Furthermore, we've worked with the Michigan Department of Health and Human Services on their request to develop test and refer programs for serum blood lead testing in Flint, HIV, and hepatitis C. These services have been implemented with no adverse patient outcomes and have been associated with dramatically improved rates of appropriate antibiotic use and high levels of patient satisfaction. It's important to point out that the patients that use these services often come from medically underserved and economically challenged communities. Unfortunately, many insurance plans currently do not pay pharmacists for these services, and therefore, outside of studies, patients may have to pay cash, and this can create a disparity in access to care. In the great state of Michigan, roughly 1,060 pharmacies, or 44% of pharmacies, already possess a certificate of waiver which allows them to perform these CLIA-waived tests. 95% of patients in the state live within 1.2 miles of a pharmacy. This makes the pharmacy uniquely positioned as a location for patients to access care. Additionally, in spite of the fact that all Michiganders qualify for some level of health insurance, 30 to 40% of individuals within the state do not recognize a primary care provider. A recent survey also demonstrated that, especially among younger individuals, that within 5 years, because of their experience during the pandemic, they envision going to pharmacies to receive care, including basic medical care, chronic disease management, instead of going to the doctor's offices. These rates are as high as 70% among millennials and 66% of those in Gen Z and Gen X, including even 45% of individuals who identify as baby boomers. Additionally, pharmacies are now designed to offer these services. We're not doing these in greeting card aisles. We're not doing these, out, in the candy aisles. But pharmacies have designated areas to administer immunizations and do point-of-care testing. Pharmacists and their staff receive training in physical assessment, pharmacology, diagnostic tests, and managing a CLIA-waived laboratory. In fact, when one of my associates was actually inspected by a state laboratory inspector back in 2011, the inspector was amazed at the level of organization and training that had occurred in the pharmacy, and commented that the pharmacy staff there was the most qualified group of individuals that they had ever encountered for offering those types of tests. Currently, unfortunately, pharmacy-based test and treat services, which is really an important thing, because if you just have a patient in and test them and tell them to go see their doctor, that's not an efficient way for care, especially with some of these cares like for influenza and COVID, where there's a time element to receive treatment. And so needing to refer patients, especially those that might not have a primary care provider, becomes problematic. Additionally, having to find an individual to sign off on a collaborative practice agreement can be difficult, especially for individuals in small areas who don't have as close of a relationship with some of the physicians as in larger areas. Lastly, we need to find a way to allow pharmacists to recoup costs that are associated with these services. You know, the billing to pay for the test and for the services, because still, even in a community pharmacy, these services can be provided to the patients at a high level for a fraction of the cost, where some of these patients may have to go if it goes to an emergency department, physician's office, or urgent care. So just to summarize, you know, the needs right now are really to enforce that pharmacists can independently order and perform CLIA waive tests. This is already allowable under federal guidelines and federal legislation. We need to be able to identify protocols that would allow pharmacists to independently dispense treatments under a statewide protocol for a variety of key conditions such as influenza, COVID, and strep. Additionally, I would like to not have this be a one and done. I would like to revisit this in the future so we can look to grow and we can look to revise so we can make this a very good bill for the people of the state of Michigan. Thank you.
Thank you. I want to return to a couple members' questions. So Representative Thompson, do you want to ask your question again?
You said the training was given to the pharmacist on injection site managing reactions. Can you tell me a little bit about that training, what that looks like, especially in a child, and then how long training that you do receive? Is it a weekend program, and is it 10 weeks? If you could expand on that, thank you.
Certainly, I'd be happy to. So the way the bill reads is that the Michigan Board of Pharmacy would identify which training program in specific we would need to complete in order to operate under this legislation. That said, the gold standard is the training created by the American Pharmacists Association. It's a combination home study program, which I believe is in the neighborhood of 8 to 10 hours of home study, and then a live seminar that is a day-long experience where injection technique is assessed on site by individuals who have already been certified. Typically, the injection technique mechanisms that are assessed are either the intramuscular injection, typically given through the shoulder, the deltoid muscle, and then subcutaneous in the tissue under the arm.
If I could as well add to that, in terms of the colleges of pharmacy, all future pharmacists are now trained to develop or to administer immunizations in the curriculum of colleges of pharmacy. All the students undergo a training program as described by Eric. As well, on the last year of their training, they undergo clinical rotations for a full year. During this time, they do have experience where they are overseen as they're administering immunizations as part of their practice.
That's prior to even getting their license now.
Yes, that is.
That was my question when you were talking about knowing the difference between an IM and a SQ.
Yes.
Okay. All right, thank you.
Yep.
And then Representative Schmaltz, did you want to go back to your question?
Thanks, Chair Rogers. Yeah, my question was just, is this going to be a requirement for every pharmacy to have somebody who can do this, especially in rural areas?
Thank you, Representative. So this is not a mandate that pharmacies engage in this program. It is merely an avenue that if the pharmacy has appropriately trained staff and it makes sense for the patients in their community to engage in this program, it authorizes them to do it, but it does not mandate a requirement that a pharmacy has to do this. So anyone who is uncomfortable or inappropriately trained would not be forced to engage in services such as these.
Thank you.
Representative Farhat.
Thank you so much for that testimony there. I wanted to just ask a little more about when we talk about test and treat, and if you can talk more on that component. As you know, we saw during COVID-19, pharmacies really being called into service very quickly, very rapidly, to meet the need of a global pandemic. What was the preparedness like then versus now for our pharmacies? And how well situated are, and I know this is it's still optional, pharmacists still have to seek additional training to be eligible to even do test and treat, they have to be certified to do it. But, how are the outcomes for patients typically in both of your practical experiences at the clinical level?
Wow, that's a big question. I mentioned that I've been doing this since 2007 in preparation. I'm the doomsday guy. And so I've been preparing for the pandemic since 2007. And I can only imagine what it would have been previously. Before the pandemic, we had only probably trained probably around 4,000 or 5,000 pharmacists. During the pandemic, we stepped up and we trained very quickly existing licensed pharmacists, technicians, and interns. We're making headroads into getting these types of training now incorporated into pharmacy school curriculum. So I think it's been recognized now that this is a very important means to provide care for pharmacists. In terms of legislation across the country, in addition to the emergency authorizations that were passed, a number of states, including Florida, Kentucky, Iowa, Virginia, also passed legislation that would allow pharmacists to do these types of services because they realize that for things like influenza and COVID, the treatment's pretty straightforward. If you have a positive test or have a high risk, and we train individuals not only just to rely on the test result and test everybody willy-nilly, I think that's a scientific term, but also
Defer to your expertise on that.
But also to allow them to determine who's the candidate for those tests. And then based off those tests, because of the short window for treatment, we're able to get them the treatment that's outlined by the CDC very quickly. In terms of the patient outcomes, when we were doing the studies, we initially managed all patients, tested them, whether we treated them or not with prescription medications. We called them back in 48 to 72 hours to see how they were doing. All the patients did well.
That's excellent. Yeah. No, I appreciate you for sharing that insight. I think there's definitely a public health need here and a state readiness need, right, to be prepared for the next potential pandemic or widespread outbreak of infectious disease. And I think it's become abundantly clear that our pharmacies are these community health anchors in a lot of cities and a lot of rural and areas and difficult service areas. So thank you for sharing that insight.
And if I could, as a follow-on to your question, a lot of these tests historically maybe have been criticized because of the lack of sophistication for the technology. Now the CLIA-Wave tests that are out there for a lot of these are very high-level molecular type tests. So they're very, very accurate, have very good results. The unfortunate thing is they're expensive. And that's why allowing pharmacists to offer these services during non-pandemic times, to allow them to pay for the equipment, the machinery, the training, to allow them to be there in times of need is important rather than trying to plug holes when the next pandemic comes.
Thank you so much for that insight. Thank you, Chair.
Thank you. Representative Conlon.
Yeah, just to be clear, we are talking about childhood vaccines as well, right? And like whooping cough and tetanus and measles.
Correct, Representative. The way the language in the bill is worded, it's any individual age 3 and up for a qualified immunizing agent, which is anything that is recommended by the CDC's Advisory Council on Immunization Practices, or anything authorized under FDA emergency order.
And I would imagine that this would increase, even though we might not have the actual knowledge on what our rate is of our children, our toddlers in Michigan being vaccinated. I would imagine that less than 50% are up to date on their vaccinations, if I had to think about it. I'd also add, I raised 3 children in Europe and used my pharmacy for almost everything. When you have 3 children under the age of 7, I barely went to the doctor. The pharmacist did everything for me to take care of 3 kids and made my life much easier.
Yes, Representative, and I agree with you. The intent would be to help the overall healthcare ecosystem by improving these immunization rates. I mean, I can speak personally as a parent. My child's well-child visit is in the spring because that was when they were born, and then to arrange a separate visit to go and get their annual flu shots is sometimes challenging. I can imagine it is only much more challenging for individuals who do not have reliable access to healthcare services, whether it be due to socioeconomic issues, provider availability, transportation, et cetera. This is just meant to be an extension so that we can reach the most vulnerable patients in our population that much more easily.
Thank you. I'm going to pause questions a minute. I'm going to let you gentlemen stay up and get to our last presenters to testify, and then we'll have the questions keep going because it may be multiple people that need to answer them. So from the perspective of pharmacies and retailers, we do have Amy Drum with Michigan Retailers Association, as well as Michael Sleeman, who is Vice Chair of the Michigan Board of Pharmacy and is representing Walgreens. Welcome.
Good morning. Thank you, Madam Chair and members of the House Health Policy Committee. Happy to join our friends and colleagues over here. My name is Amy Drum. I'm the Senior Vice President of Government Affairs for Michigan Retailers Association, and I'm joined today by Michael Sleeman, a Walgreens pharmacist who also serves on the Michigan Board of Pharmacy. Now, before I turn things over to Michael, I'm going to be very brief because we've already covered a lot of the important pieces of this legislation, but want to give you an overview of why we are also supportive of Senate Bill 219 and why we urge the committee to act quickly on this legislation. On May 11th, the federal allowances that granted greater access to vaccine administration did expire, and that puts patient access to healthcare services at their local pharmacy in jeopardy. Senate Bill 219 seeks to continue that care that Michigan's pharmacies and pharmacy technicians have been providing over the last 3 years. Now, while COVID vaccines and testing allowances were extended, those too will expire in December 2024, as you've heard, if the legislature does not act this term. And we may not be prepared for the next health crisis if one were to arise. Throughout the pandemic, Michigan's pharmacies never closed, and they were a source of critical healthcare access when other providers were less available. The convenient locations and hours offered at local pharmacies play an important role in their ability to safely provide over 10 million vaccinations between 2019 and 2022. 50% of those pharmacy COVID vaccination sites were also located in areas with high social vulnerability. And so as you've heard, this is a very critical piece to access where folks do not have the same reliable healthcare system. As you've heard today, Senate Bill 219 is needed urgently because without it, pharmacists and pharmacy technicians are unable to offer access to ACIP vaccines for children ages 3 to 18 unless the pharmacies entered into a collaborative practice agreement. So you've heard that those agreements already exist, but not every pharmacy location has one in place. And without those, they are currently not allowed to continue that access to care. Now, as we've heard questions about referrals to well patient visits and well child visits, we believe that the pharmacies are well positioned to provide a reminder to patients and parents that they do need to go see their regular physician. They should get a regular physician and visit them regularly. But this provides, again, access in the moment to get their vaccines when needed. And so we are trying to provide additional access and care points where they are maybe lacking currently. Not all pharmacies, as I mentioned, have a collaborative practice agreement in place. Those smaller independent pharmacies in particular are less likely to have one, meaning residents using those pharmacies, many of whom are already living in a medically underserved area, may not have access to those vaccines at their local pharmacy right now. Michigan residents, as we know, utilize the additional care options provided during the pandemic, but those care options will remain limited if Senate Bill 219 is not approved quickly. Vaccine access, testing, and treatment for COVID, flu, and respiratory illnesses specifically will be reduced even further if this legislation is not adopted before December 2024. I do want to thank the bill sponsor and members of the committee who sponsored similar legislation for their hard work on this issue. We look forward to continuing to work with all of you on providing more and increased access to pharmacy care and access points at Michigan pharmacies through future legislation, hopefully. And we want to just note that a lot of hard work went into reaching the consensus found in the Senate-passed bill before you, and we greatly appreciate those efforts. I also understand there may be a friendly cleanup amendment to the language to help clarify one piece, and we would support that change as well. So on behalf of our retail pharmacy members, I want to urge the committee to act quickly and approve Senate Bill 219 to continue the convenient access and affordable care provided at Michigan pharmacies today. And now I'll turn this over to Michael Sleeman, who can offer a more specific experience and expertise.
Thank you, Amy, and thank you, Chair Rogers and members of the House for this opportunity. I just want to share why I support this bill as a pharmacist in the field with my experiences and my experiences on the Michigan Board of Pharmacy, and hopefully address any concerns. Just a little background, I've been a pharmacist for over 7 years. I've worked both on the retail side. I've worked with Meijer. I own my own independent pharmacy, and now currently I'm with Walgreens as a pharmacy manager. I can honestly say from all my years of experience in the different sites and different locations that there's definitely a huge need for this. To add to what Amy said, pharmacists, interns, technicians were called upon to administer vaccines and point-of-care tests independently during COVID for almost 3 years. We stepped up and we administered millions of vaccines throughout the country and the state safely and effectively. Why should residents of Michigan miss out on having this high-level access of care and service to their pharmacies or from their pharmacies moving forward? Pharmacies play a significant role in providing access to care. Studies show about 60% of Americans seek non-emergent care first at a pharmacy. I know this was touched on already, but briefly, in regards to CLIA waiver tests, by definition, the Federal CLIA Act of 1988, a CLIA test is defined as a simple test with low risk for incorrect results, including tests cleared by FDA for home use. The federal law actually defines this test as so simple that even Mickey Mouse could administer this test at home. Some key statistics is laws and rules address pharmacists as independent immunizers in over 17 states currently. And laws and rules address pharmacists have independent authority for point-of-care testing in over 22 states currently. Studies have shown that patients prefer point-of-care testing available at pharmacies and are willing to pay out of pocket for the convenience and ease of access. And to be honest, I see this all the time. Patients come in and they ask, can you test me for this? Can you test me for strep? Can you give me Paxlovid? Like, they don't want the convenience of going to a pharmacy, and it's more cost effective for patients and the payers. From a board of pharmacy perspective, the board is here to protect the public and ensure patient safety. From my experience on the board, we would plan to ensure and evaluate and regulate at the highest of standards of practice. Looking at what other states have done safely and effectively, you can trust that the Board of Pharmacy will regulate with these allowances to protect patients in the great state of Michigan. Lastly, in Michigan, we have been entering into collaborative practice agreements with prescribers for vaccines, prescribing, test to treat, and many other patient-based services for years. If you remove the agreement itself, do pharmacists suddenly not know how to administer vaccines or provide these tests? No, we have proven over many years of success and continue to do so based on our doctorate level of education that have prepared us for these services. And as Amy stated, we just want to say that we fully support this bill and thank you to the sponsors. But it does need some clarification, so I believe we are working on a substitute. Thank you.
Thank you. We're going to return to some questions. So I have up next Representative Glanville, then Reingans, then Hadsma. Representative Glanville.
Thank you, Madam Chair. I'll be brief. I feel like my point has been mentioned, but I just want to reiterate we've talked many times in this committee about equity and access and things, and I think that this bill is a great opportunity to act on that here, considering how many folks, as we've heard, in underserved communities, maybe even underinsured, uninsured, that sort of thing. So I just want to throw some support behind that equity piece that, like I said, we talk about quite a bit. So thank you.
Thank you. Representative Reingans.
Thank you, Madam Chair. I have a question and a follow-up on one of my colleagues' comments earlier. So for the pharmacist, it's a scope of practice question. In my mind, I don't see an expansion of pharmacy scope of practice, and I also don't see an usurpation of other providers' scopes of practice. Can you clarify if that's accurate?
That is accurate. This is not an increase in the scope of practice.
Okay, thank you. And then my clarification, Rep. Conlon had said in a wondering voice whether or not we had half of our kids vaccinated. So I just want to clarify that in Michigan, more than half, and nearly over 90% of kids by the time they start elementary school this school year are vaccinated and up to date on their vaccines. And there's a lot of data sources that I'm not going to get into, but I had to double check it before I could respond. Where we fell on that. So thank you, Madam Chair.
Representative Hadsma.
Thank you. 5 or 10 years ago, I recall a business story. I think it involved a national chain like CVS, where this national pharmacy was going to work with, I believe, a health insurer and bring in a walk-in clinic associated with its services. I haven't heard much about that since that story. It might have been lost in COVID stories. What's the status of that? Was it successful? Is it still being experimented, if anyone knows?
Yes, Representative. I can say that the walk-in clinic model is still being experimented with in various locations. Especially several of the large pharmacy chains have implemented service models where they'll bring in other medical providers, aside from pharmacists. Where this model differentiates from what we're looking at here is, one, those walk-in clinics have a broader suite of services, and two, they're also harder to implement in rural areas where patient access is a challenge, just because the patient population has to be able to sustain such a model economically. So that is still out there, and it's working very well in certain situations. But I believe that the type of practice that's addressed in this legislation is different and needed in addition to that kind of model.
Thank you.
All right. Thank you so much to everyone for giving testimony and great questions from the committee. I will read in some cards of support. Supporting SB 219, we have Meyer. Supporting the bill, Walmart. Michigan Association of Health Plans supporting. Michigan Manufacturers Association supporting. Walgreens supporting. Michigan Health and Hospital Association supporting. Department of Health and Human Services supporting, Michigan Council of Maternal and Child Health supporting, and Michigan Chamber supporting. The next meeting of the House Health Policy Committee will be June 15, and I expect to vote out SB 219 at that time. Please share any additional concerns with the bill sponsors in my office prior to that meeting. Representative Reingans moves to excuse absent members. There being no objection, the motion prevails by unanimous consent. There being no further business before the committee will stand adjourned.